Okay, I'm privileged to introduce you to our final presentations by Dr. Thomas Duplinsky and Dominic Cicchetti. Dr. Duplinsky has a private practice in Hamden, Connecticut since 1989. He's been in practice over 52 years and a member of the IAOMT for over 20 years. Dominic Cicchetti has his PhD from the University of Connecticut and has over 287 publications. Please give a warm welcome to Tom and Dominic.
And I guess to start, I have to read a disclaimer that basically we have no financial interest in anything that we're talking about tonight. If that's adequate. So basically, we did this study concerning the exposure of the health of dentists, actually. So everyone, the literature is strong on the fact that the dentists show a higher urine mercury level and a higher mercury body burden than the general population. And basically, what the defenders of the continued use of mercury amalgam fillings state that there's no evidence to suggest that dentists suffer any ill effects as a result of this higher exposure to mercury. In fact, based on mortality studies and surveys, a number of authors have argued that dentists tend to be healthier than the general population. Authors go even further to say that finding that dentists as a group have a higher mercury level than those associated with people with amalgam restorations but experience no increase in disease or death rates is an important reassurance to both patients and dentists with respect to the safety of amalgam. So basically you have this group that says that we can continue to use this product because dentists who have a higher body burden really are unaffected by that. So we decided we would look at that. But basically, just as a quick review, we have the mercury thermometer, which has 500 to 600 milligrams of mercury and is encased in glass. It's actually fairly safe in glass until if you drop that in this room, we would actually have to evacuate the room. And it's banned in most states in the United States and in most foreign countries. Then you have the mercury filling, which has 750 to 1,000 milligrams of mercury, and then basically this is considered an alloy, when the truth of the matter is metallurgically this is not an alloy at all. Metallurgically this is a solid solution. And what happens with a solid solution metallurgically is that from the moment it's placed, the mercury begins to evaporate and will continue to evaporate. And then just to get an idea of the amount of mercury that is in this is basically it would be 1 million micrograms as we talk about micrograms. So you have a reservoir in the single tooth of a million micrograms of mercury. And as I was introduced, I work in the medical school part-time, and I also have a private practice part-time. And this is the mercury separator in my office. And in that mercury separator is, in Connecticut, and there are some states apparently that don't still require this, but if you cut out silver fillings, you have to have a mercury separator so it doesn't get into the wastewater. So this is in my office, we have this collection, and this is about 2 kilograms of mercury sludge that you have to get rid of. Now, in the state of Connecticut, if you dispose of any scrap amalgam or this sludge, if you do it improperly, it's actually a $75,000 fine. And now I have to thank Randall Moore for some of the mercury tracker slot, and just to give a concept of the exposure that dentists have. And this is the mercury trap. There's particles of mercury in this trap that are collected. And this is a reading of 270 micrograms once you take the lid off. And this is a newly placed filling that has coming off of it is 450 micrograms per cubic meter. And basically, if we consider the World Health Organization for an 8-hour exposure is 25 micrograms, and the OSHA limit, 100 max, of which, basically this is the, if this is in a room, you actually have to leave the room. And this is what's coming off of the filling, a newly placed filling. And this is even more telling, and this is more important for us as dentists, is what is happening when you actually cut these fillings out. At a much greater exposure. This is measuring 2,300 micrograms. And who's getting that puff is actually the patient, your assistant, and you, if you're unprotected. So just as a review, what the literature says is, the average dentist has 5.8 micrograms. I put this slide in because you can see that in the urine mercury is not a good indicator of body burden, and we're really interested in the body burden. And this is one study where we have a DMPS challenge, a chelating agent, and you could see that we start off with the dentists prior to chelation, and you get quite an increase of mercury being excreted because of the chelation. And then this is looking at autopsy studies. We have 3 dentists and 4 controls. And basically, there's quite a difference between the controls in the pituitary gland, now this particular study. And what's interesting is that this really should be 0 anyway, because you shouldn't really have mercury in your body, and certainly not in your pituitary gland. And if we look at this is another study, which had a mean for the dentists of 815 in their pituitary gland compared to the controls of 23, and you had it went in a range from 135 to 4,000 of micrograms per kilogram, and that's looking at the pituitary gland, and then the renal cortex, 1,500 compared to 180 in the controls. And then there's one dentist had 28,000 micrograms in their thyroid. There wasn't a control for the thyroid in that particular study. The other interesting thing is the literature. There are 2 references about the dentists and brain tumors. And these 2 papers state that there's a 2.5 times greater risk of glioblastomas, gliomas, and meningiomas. And it's an interesting little side story is we published our paper in October, and just a few weeks ago I gave a copy to the Shine rep that comes to my office, and he read it and he came back a week later and he said, that's a very interesting paper that you wrote. And he goes, do you think that's why these people, the dentists, are dying of brain tumors? And I said, what are you talking about? So he rattled off 8 names in the people that he calls on, and of those, the 8 people that he calls on, this is a single rep, mind you, and of those people, 6 were dead and died within the last 2 years, or a year actually, and 1 was actually a pituitary gland tumor, and the others were actually, the other 7 were brain tumors. So this is this Shine dental rep telling me this story. And this is just the people he called on. And this is just in New Haven, the New Haven area. So then he made this really bizarre comment, and he was, incidentally, what he's doing now is he's actually just asking his other fellow reps if they have any adverse health effects in the people that they call on. And then he made an odd comment. He goes, well, I bet it's the carpeting. And I said, what do you mean about the carpeting? And this guy is pretty astute. And 6 of the 8 dentists had carpeting in their operatory. So then this brings in all the work that Dr. Young and Dr. Palmer are doing with particulate. And here's the very astute Shine rep, and he goes, we don't like putting carpeting in operatories because I guess somewhere along the way, it's, if you have mercury spills and things like that, you don't want to have carpeting. So it's a very interesting little side story that this one Shine rep, 8 of his dentists died of brain tumors, and might be another study. So during the study period time, 85% of the dentists both removed and placed fillings, and also the typical dentist removed between 2 and 10 amalgams per day. And this is really where the the greatest exposure comes for dentists. Basically, therefore, all general practice dentists are exposed to mercury vapor, whether they use amalgam or not. But basically, do I see, for a show of hands, how many are dentists in this room? Okay. And how many are mercury-free dentists? Well, you might want to think about that for a minute. At the end, we'll talk about whether such a thing exists. But right. So that's the thing. So we'll talk about that in a few minutes. But now, how did the idea for this study come about? Just like the Shine Rep, I don't know, I'm just hanging out, and then people just come to me and start talking. And I was talking to a third-party administrator, and they asked me this question: why do dentists get unusual brain tumors, and why are they such high utilizers of health care? This particular third-party administrator has over 300,000 people that he insures. And then I started talking to some major insurance companies, and it became obvious that they do not like to insure groups of dentists because these groups have high medical loss ratios or high pay loss ratios. And this is based on their data, and is actually anecdotal for us because they won't share this data with us directly. So the insurance companies actually already know. The third-party administrator was having a tough time with his dentists, and this group of dentists, getting them covered, and also trying to keep the premiums down. The insurance companies like to charge dentists more to insure them for health care. So, how can the health status of a population of dentists be efficiently and effectively measured was one of our thoughts. And then if you have different methods, you have surveys, interviews, hospital chart reviews, and mortality studies. And there's a lot of weaknesses in the different things. Like if you do a subjective survey and you ask the patient or the person what they have, I mean, a schizophrenic person is not likely to say that they have any mental disorders. So, and then the mortality studies are interesting because the difference, first of all, they're fairly old. The mortality studies that were done in like the 70s, and basically the difference is like a year or 1.1 year. And the thing is that it may be, and our contention ultimately is that the dentists do live slightly longer than the average population, but they also have the finances and the access of care, whereas oddly enough, most of the populations don't. And the other weakness with the mortality studies is that very little is based on autopsy, and it's multiple medical examiners, and there's limited autopsy results actually in these studies. So the concept was developed to use insurance utilization as a tool to determine the health status of a population of general dentists. And it was further refined to use pharmacy utilization as an indicator of health. And the thing about this is that insurance utilization data is a direct measure of what medical condition the patient is being treated for. It's not you're asking the patient what they might think they have or having someone else. It's actually a direct measure of what the condition they're actually being treated for. And we use pharmacy utilization data as a tool to determine what diseases the subject is being treated for. And how strong and accurate is this method? Well, the test of using this was to look at medical claims versus pharmacy claims data. And basically, we use the ICD-9 codes. And for 400 dentists in the study group, we had both pharmacy utilization data and the medical claims data. And if we look at this chart over here, we looked at these disease categories. And so we had the actual medical diagnostic codes and the drugs that were used for that. And so, for instance, the epilepsy, gabapentin, and Parkinson's disease, levodopa, and on and on. And then we had, of course, the bipolar affective disorder. And so we actually know for certain what the dentists were suffering from. And off-label use could be a criticism and a weakness of the study. However, the way our groups are, and the categories we used mental disorders, nervous system, basically respiratory and circulatory. So these are the categories we looked at. We could have looked at kidney disease and things like that, but we actually didn't. We only looked at things that these particular categories. And basically, Elavil is an antidepressant that can be used for treating neuropathic pain, prophylactic migraine headaches, and burning mouth syndrome. And it's not used for cholesterol to prevent cardiac disease. So it would fall, with some overlap, but actually we would capture it in the psychiatric or the neurological. So basically, our main question was, are dentists as healthy as or healthier than the general population? So what we had pharmacy benefit manager and a third-party administrator that were contacted in order to obtain data. And the pharmacy benefit manager insures over 200,000 people in the northeast section of the United States. And from this geographic population, we took a group of 600 dentists. They provided us actually 600 dentists and matching controls. Now these controls were actually matched they had the same drug card, same drug plan, equal access to care. So, and same geographical area. In fact, many of them had the same physicians treating these patients. And I'm going to pause, and Dom is going to talk about the statistical analysis.
Okay, the model accounts for all prescribed medications, whether or not they're used by a given dentist or control. The dependent variable becomes the amount of prescribed medication for defined diseases that dentists show relative to controls. No, I did that. Yeah, I've got it.
There you go. Got it.
Right.
Okay.
Now, Tom referred to the matching of the study groups. This is specifically how we did it. It was demographic matching. The two groups were matched on gender. They were all males. Geographic area from Connecticut. Pharmaceutical benefits manager. Prescription drug card and card restrictions, which Tom mentioned. And then age distribution. We had the youngest, 25 to 34, followed by 35 to 44, 45 to 54, and the oldest, 55 to 64. Oh, I'm sorry, I did that the wrong way. Now, the purpose of the study, as you probably gathered by now, is to compare the health status of age and gender-matched general dentists and controls in 5 disease categories: psychiatric, neurologic, psychiatric and neurologic, respiratory, and cardiovascular. Okay, we've done that. These are the exclusionary criteria. Specialty area dentists, because of their limited numbers, were excluded. And females were excluded for the same reason. And dentists who self-prescribed, and some of them did, were also excluded in order to avoid a potential bias. We had 3 hypotheses. One was that for each illness category, over all age groups, the dentist will demonstrate more pharmacy utilization than controls. Secondly, for each age category, dentists will manifest more pharmacy utilization than controls. And the third one, this is an interesting one, there'll be an ordering of pharmacy utilization such that both dentists and controls will demonstrate more pharmacy utilization with increasing age, as you would expect, but dentists will demonstrate more pharmacy utilization than controls at the various age groups. The first hypothesis was confirmed. The results across the combined age groups in terms of, and I rounded these off to the nearest percentage, I'll give you the full table as my last slide. For psychiatric illness, 12% utilization by dentists, 5% by controls. For neurologic, 6% versus 1%. For combined psychiatric and neurologic, 15 to 6. For respiratory, 21 to 15, and for cardiovascular, 27 to 16. The second hypothesis was also confirmed. There were 4 age groupings, as I pointed out to you, by 5 illness categories, or 20 comparisons in all. And when you make multiple comparisons, as we know, you increase the probability of getting results by chance alone, so we controlled for that. We're always working at the Holy Grail 0.05 level of probability. In 16 out of 20, or 80% of the comparisons, dentists in fact showed higher pharmacy utilization than controls, and this was especially pronounced at the older age groups. The third hypothesis was confirmed in terms of the ordering of ages within study groups. The statistic used here was John Kira's 1954 Z-test for the significance of an ordered trend using a program that was developed in my lab a number of years ago. So what's happening here is we're saying the groups are going to order themselves by age within dentist and control. Now, interpreting the John-Kira test, it produces a z-value. And if you remember Statistics 101, when you looked at a t-test, was there a simple difference in the averages or means between two groups? And you look at a table of t-values. When you get beyond 60, you'll see the infinity sign. And it'll say 1.96. So with large sample sizes, a z-value essentially of 2 tells you it's statistically significant. And a one-sided test means the results can only go in one direction, which really is what we're talking about here, even though I was very conservative about it and allowed for two-sided as well, but you'll see from the results it didn't matter. One-sided means the results can only go in one direction. Here, the dentists show more utilization than controls at each age group. I mean, the reverse of that would be ridiculous. But at any rate. And here are the z-values and the probability that the result occurred by chance alone, and for one-sided and two-sided. And you can see by the time you got to a value of 3, you're talking about the probability of chance occurrence being only 1 in 1,000. And you'll see the values we got were much higher than that. Okay, here was the ordering for psychiatric illnesses. Okay, and you can see that trend that in general, both groups show an increase with increasing age, but in general it's the dentists, especially at the higher ages, who show a lot more utilization of these specific medications for specific illnesses. Now here, this z-value was almost 5. Remember, 3 was 1 in 1,000. This was less than 1 in 10,000. And similarly for neurologic illnesses, and for the combination of psychiatric and neurologic, Z is all the way up to 6. And for respiratory, that is a two-tailed test there. One-tailed test would be a probability level of 0.03. And finally, for cardiovascular, the z-value went all the way up to 12. Like 1 in a million sort of finding. This now is my final slide before Tom comes back here to tell you what it all means. And this is more detailed than when I showed it to you the first time, so you could get a feel for what the numbers were, what the tests were that we used, and what the probability levels were, and what the confidence intervals were around the values. So the chi-square test, 1, 2, 3, 4, 5 columns over, Chi-square is statistically significant when you're comparing two percentages if the value is 3.841. This value was 16 for psychiatric, 24 for neurologic, 29 for the combination of psychiatric and neurologic, almost 8 for respiratory, and 18 for cardiovascular.
So basically, it's very well established that dentists have a higher body burden of mercury through many studies than the general population. So one of the primary things that we were really our main objective was to probably put to bed the notion that dentists are healthier than the general population, which various groups that propose the continued use of amalgam have used as a defense. They say, well, the dentists have very high body burdens, so what are you worried about? They have higher mercury than people with mercury fillings, and they're not sick at all. They're actually healthier than the general population. So clearly, we looked at that point. And these are just some of the things that we actually, some of the conditions, basically. We had patients with Parkinson's disease, a number of seizure disorders, migraines, and psychiatric issues. They were being treated for depression, anxiety and panic disorder, obsessive compulsive disorder, insomnia, bipolar disorders, and schizophrenia. So, and I pause here just with the migraine to bring out this point. People are under the impression that migraines are vascular diseases when in fact the current thinking of 2013 is that that is not quite correct. And there's 36 million people in the United States that suffer from migraine, and it has no known cause. And the triptans are vasoconstrictors. That's why they said it's a vascular issue, but it's actually triptans have a direct neurological effect. And it's a complex disorder involving both the cortex and the brain stem. And there's now issue whether there are triggers at all. And it's a disease of hyperexcitability in the brain and has the characteristics of a seizure disorder. And in fact, many authors believe it is a seizure disorder, migraines. And the reason I bring this up is we saw significantly more migraine actually in our dentists than we did in the control group. So this is sort of a summary. The neurological findings were 7.6 times the control. The psychiatric were 2.4 times the control. And in combining those two, it was 2.8 times control. Cardiovascular is 1.7 times control, and respiratory 1.5 times control. And there's a bunch of review articles that for cardiovascular that have quite a relationship with how mercury affects cardiovascular disease. So what can we say? Basically, one thing we can say by this study is that a higher mercury body burden does not make dentists healthier than the general population, as some authors prefer to believe. And the major ramification of this study is that general practice dentists are at greater risk of developing certain diseases than the general population. Which brings us to us. I'm a dentist, you're a dentist. Now, I asked how many people are mercury-free dentists? How many do we have out there that are mercury-free dentists? There are no such thing as mercury-free dentists because of that first slide. And let me just go through this. Basically, my viewpoint is as of March 16, 2013, there's no such thing as a mercury-free dentist. Even if the dentist is not placing mercury fillings, they are removing mercury fillings in the normal course of their work, emitting high amounts of mercury vapor. And I could add to vapor from Dr. Young and Dr. Palmer's work that it's actually particulate is even more of a concern than the vapor. So that brings us to this slide, which is originally the state of the art, but basically this is what's wrong with this picture. There's a lot wrong with this picture, but basically now we have to rely on Dr. Young, Dr. Palmer, Dr. Warwick, and Dr. Virtue and their work to try to, this is again taken from the IAOMT site, and this is how to protect yourself in the dental office. And these, this is again the removal. You have the patients protected with an air source, but there's a number of things that are defective And as far as you have to protect yourself more than this, actually. But the main point I'd like to drive home to this audience is that the greatest risk, if you saw that first slide where they were we show cutting out within the mercury vapor meter, you're getting over 2,000 micrograms per cubic meter being emitted. And if you have no protection, you're going to be in serious problems, and you'll be part of the study group, and you'll have 7.6 times the neurological problems of the general population. So this is to drive home, and there's a bunch of new members that should also be concerned, and there's a number of vendors, and Dr. Young gave a beautiful talk yesterday of how you need to protect yourself. So in conclusion, basically, there's exposed skin here, the patient's exposed, and there are other people in this audience actually know better than me what's actually missing. But our basic point is that there's no such thing as a general dentist that is mercury-free, and that means that you're at very high risk, and you have to really protect yourself, or you're going to end up with some very severe neurological problems. So, there we go. Thank you.
Thank you, Dr. Duplinsky and Dominic. The AGD code is TD0316HS. TD0316HS. And we can move right into our speakers forum. If somebody would help me bring some chairs up here, and we can have all of our speakers from today at the front, and you can ask questions.